Good afternoon. We're about to begin. Can everybody hear me?
Yes, sir.
Yes, sir.
Everybody seeing the slide okay?
Yes, sir.
All right. So we're going to be continuing with the trauma module. We're moving on to the third chapter. Well, I won't be going in sequence, but this will be the third chapter from that section. So we'll be looking at chapter 26, soft tissue injuries. So let's get right into it. All right. Soft tissue injuries are common. Can be something as simple as a cut or scrape, or it can be as serious as a life-threatening internal injury. Do not become distracted by dramatic open wounds, right? So don't allow how the wound appears to distract you. You need to remember that there's a patient attached to the limb or that wound. So you need to focus on your patient first and ensure that the ABCs are good. Everybody else hearing me? Apart from Nurse Dennis. Nurse Dennis is having a connection problem. Everybody else present, can you hear me?
Yes, sir.
Yes, sir.
All right. So if Nurse Dennis cannot hear me, the issue is on her end. All right. Now, soft tissues of the body can be injured through a variety of mechanisms. Yeah, blunt injury, penetrating injury. We're very much familiar with that at this stage. You have barotrauma, which is from pressure, and you have burns. Soft tissue trauma is a common form of injury. Death is often related to hemorrhage or infection. Your priority in the field is your focus on bleeding control. Infection prevention would be secondary. So primary will always be to control bleeding or blood loss. Secondary, you think about infection control measures. Soft tissue injuries can often be prevented by simple protective actions. Now, the organ involved mostly with soft tissue is going to be the skin. The skin is the body's first line of defense against external forces and infection. The skin is relatively tough, but still susceptible to injury. Can range from simple bruises and abrasions to lacerations and amputations. In all instances, the EMT must control bleeding. As I said, that will be your first priority. Control blood loss. Once it's an open wound, that is your priority first. Bleeding control. Secondary, prevent or decrease the risk of infection and protect the wound from further damage. You apply dressings and bandages to various parts of the patient's body as needed. The skin varies in thickness. It is thinner in the very young and the very old. Thinner on the eyelids, lips, and ears than on the scalp, back, soles of the feet. Thin skin is more easily damaged than thick skin. So you need to be familiar with the three layers of the skin. The skin has two principal layers, epidermis, which is the top layer, and the dermis, which is the inner layer. I have the subcutaneous, right? So you have the epidermis, which is the top layer. You have the dermis, which is the middle layer. That's where you have your blood vessels, nerve endings, right? Sebaceous gland, and you have the subcutaneous tissue. The skin covers all the external surfaces of the body. Bodily openings are lined with what we call mucous membranes, right? Which we can sometimes examine to determine if a patient has good circulation. Provide a barrier against bacterial invasion and secrete a watery substance that lubricates the openings. The skin have multiple functions, which include um, keeps pathogens out, or keeping pathogens out, keeps fluids in, helps the body to regulate temperature, and it acts as a sensor to the environment. So it picks up changes in the environment and relay that information to the brain. Any break in the skin may allow bacteria to enter and increase the possibilities of infection, fluid loss, and loss of temperature control, right? And that's the revision of the skin's anatomy and physiology. 3 types of soft tissue injuries can affect the skin. You have closed injuries, which damages beneath the skin or mucous membrane. So the surface of the skin is intact, but underneath there is damage. I have open injuries, which is break in surface of the skin or mucous membrane. And once there is an opening in the skin, there is exposure to deep tissues and they can be contaminated. Then you have burns, which are damage or wounds to the skin or injuries to the skin from thermal, frictional, toxic chemical, electricity, or nuclear radiation, right? Damage to the skin as a result of heat. Now let's look at the pathophysiology. Cessation of bleeding is the primary concern. I've said this more than 2 times up to this point. Or immediate concern once there's an open wound to the skin, we need to control bleeding. Next, wound healing stages, inflammation. A new layer of cell is then moved into the damaged area, right? So this is how the skin repairs itself. If there's injury, the first thing that the body needs to do is control the blood loss that is occurring. Next, wound healing, and the inflammatory stage. Then you have new layer of skin forming, and eventually we get new blood vessels forming as well. Then you start to get collagen, which provides stability to the damaged tissue and the wound borders. Now, let's look at closed injuries. Characteristics of closed injuries. History of blunt force trauma. There will be pain at the site of injury. There can be discoloration or you can see swelling, right? So you can have discoloration and you can have swelling. And there are medical terms for that. So you have a contusion, which is a bruise. Causes bleeding beneath the skin but does not break the skin. Caused by blunt force trauma, right? A buildup of blood produces a blue or black discoloration. So we have blue, when we have discoloration and there's no swelling, that is referred to as ecchymosis, right? And in layman term, it is what we call a icky, right? So the small blood vessel is damaged under the skin, and it begins to bleed, but there is no swelling, or you get discoloration from that bleeding that is occurring. That is a ecchymosis. Hematoma, I mentioned this in the previous class. This is when a large blood vessel is damaged under the skin and it is bleeding. Because it's a large blood vessel, you will get swelling, visible swelling in the area. Both a hematoma and a ecchymosis is referred to as a contusion. So both of these are contusions, right? Then you have crush injury. Now, a crush injury is when, as it states, a significant amount of force is applied to a particular area of the body for an extended period of time. The extent of the damage depends on the amount of force and the length of time applied, and if it exceeds 4 hours, the patient can develop crush syndrome. And basically what crush syndrome is, every structures within that area, after 4 hours, they are going to die, right? The muscle breakdown, electrolytes start to leak out of the cells, and whatever is in that area becomes toxic, right? So if this patient has a crushing mechanism and it's over 4 hours, whatever is in that area is going to be destroyed and it becomes toxic. And that cannot be allowed to circulate within the patient's body. If it does, it can cause serious complications with the patient heart and the patient kidneys, right? So this is what we call crush syndrome. Patient can also get compartment syndrome. So crush syndrome is over 4 hours. Compartment syndrome is between 6 to 12 hours, and compartment syndrome is more specific to a fracture. So compartment syndrome occurs when there's a fracture, usually to a long bone like the forearm, the leg. So what occurs in that particular injury is the fractured bone starts to bleed, but the blood collects into the membrane that surrounds the muscle, right? So blood start to collect in the fascia or membrane that surrounds the muscle, and it causes a built up pressure, increased pressure in the area where the injury is, and it is a limb threatening injury. What do I mean by that? If the pressure is not relieved, the patient can lose the function of the limb. So they will need surgical intervention to remove that pressure. Right? That's what we call compartment syndrome. The pressure is very extreme because the membrane that surrounds the muscle is not elastic. It don't have any elastic nature. It can't stretch. So blood getting into that membrane can quickly increase in pressure. Right? And what I just said, it's a limb-threatening injury. Crush syndrome, which was the previous one, is a life-threatening injury. Both of these injuries would require lights and siren, emergency transport. Now let's look at our open wounds. In an open injury, protective layer of the skin is damaged. The wound is contaminated and may become infected. And we have 4 types of wounds. We have abrasions, which is what we call scrape. An abrasion is a scrape. So that's when the top layer of the skin is removed and you get capillary bleeding. A laceration is a deep cut into the tissue. So that may go through the top layer, middle layer, can sometimes go through the third layer as well, right? It's a deep cut from a sharp object, or it can be a clean cut, right? like when a surgeon do an incision. So an incision is also a laceration. Now, as it can go through the top and middle layer, it can catch an artery, and if an artery is lacerated, that can cause significant blood loss. Then you have an avulsion. An avulsion is a partial amputation. It's not a complete. What I mean by that, all that is holding the limb or structure intact is a piece of skin, right? So all that is holding the limb to the body is a piece of skin. So there is a deep cut to the point that all that is keeping it attached is a piece of skin, an avulsion, right? Then you have your penetrating wounds. So let's go through these injuries. An abrasion is a wound of the superficial layer of the skin caused by friction when the body part rubs or scrapes across a rough or hard surface. And they have a picture of that. A laceration is a jagged cut caused by a sharp object or blunt force that tears the tissue. An incision is a sharp, smooth cut, which is also a form of a laceration. And if you look at this picture, you can see that this leg has multiple lacerations, right, at various depths. And when you have a laceration where a chunk of the skin is missing, you may have to pad into that space, right? So the space, that chunk that is missing, you may have to find where the blood loss is coming from, put pressure on the vessel, and then pack that area with gauze, right? To control the blood loss properly. You can't just put a gauze on it flat and wrap. You may have to pack the area. An avulsion separates various layers of soft tissue so that they become either completely detached and as a flap. Often there is significant bleeding, right? So all that is holding it together is a piece of skin. Now, the amputation is when the limb is completely severed. So an amputation is an injury in which part of the body is completely severed. A penetrating wound is any injury resulting from a piercing object, and it naturally, if it's piercing, it can damage structures deep within the body. All right, so stabbings and shootings often result in multiple penetrating injuries. So you need to assess the patient carefully to identify all wounds, right? So that means you definitely need to expose, cut and and look for if it's a gunshot wound, was the patient shot more than once, where's the entrance, where's the exit, right? Where on the body. Count the number of penetrating injuries, determine the type of gun possible, but do not delay transport. You may have to testify in court. Then you have your blast injuries. Blast injuries, primary blast injury, this is from the pressure wave. Secondary blast injuries from the shrapnel that are released by the explosion. And tertiary is when the patient is thrown against an object. Now, patient assessment of closed and open injuries. So it's more difficult to assess a closed injury than an open injury, right? Why? Straightforward. You can see an open injury. Consider the possibility of a closed injury when you observe bruising, swelling, deformity, and of course the patient reporting pain. So we start off with our scene size. So make sure that that scene is safe for you, your partner, bystanders, the patient. Observe this for hazards to your crew, bystanders, and patient. Consider the need for additional resources. Take the necessary standard precautions, right? Make sure you have enough gloves on you. If time allows, it's going to be a messy scene, put on a gown, right? If you have to do a lot of earway stuff, make sure your eyes, nose, and mouth is covered. Be careful where you put your hands, place your equipment, and how you package a patient. Focus on control bleeding. Think about the mechanism of injury. Look for indicators of the MOI as you assess the scene. The MOI may provide information about potential safety threats. Evaluate the scene safety and consider additional resources. Now, once we have completed the scene size up, the next phase of the assessment is the primary assessment. And the primary assessment is done to identify any immediate and potential life threats. So identify life threats and transport priority, right? We're in our primary now. So we form a general impression of the patient and the environment. We're looking for indicators of the patient condition. We check for more serious hidden injuries. We check for responsiveness. We will then assess airway and breathing, and we will manage accordingly. So we will provide high flow oxygen, ensure that the patient has a clear and patent airway, protect the patient from further spinal injury, assess the patient for adequate breathing, inspect and palpate the chest for decap TLS. After we finish AB, next would be circulation. Assess the pulse rate and quality. The patient is responsive peripheral pulse, not responsive central pulse or carotid pulse. Determine the skin condition, color, and temperature. Check Capri fill time, more reliable for pediatric population. You may need to treat the patient for shock. Right? Now, after your ABCs, you should know what your patient's GCS is. You should know if you need to do a load and go for this patient, and you should know if you need to do a rapid scan or a focus assessment. Transport decision. Immediately transport in these cases. If the patient general impression is poor, rapid transport. Altered level of consciousness, rapid transport. Dyspnea or difficulty breathing, rapid transport. If the vitals are unstable, rapid transport. Shock present, rapid transport. If the patient is in severe pain, rapid transport. Once we have completed the primary assessment, the next phase is history taking. Investigate the chief complaint. Obtain a medical history, obtain a sample history. And you will use your OPQRST, you will use your DCAP BTLS, and you're using sample, right? All of these together. You can get this information regarding the chief complaint from the patient, you can get it from family members, you can get it from bystanders, right? If the patient is unresponsive, attempt to obtain the history from other sources. And once they are unresponsive, ensure that you check the pupil or pupils, you check the pulse ox, and you check the blood sugar. Now, typical signs of an open injury: bleeding, break in the skin, shock, hemorrhage, disfigurement, or loss of a body part. Now, once we have completed the history taking, the next phase will be the secondary assessment. Right? And the purpose of the secondary assessment is we will be doing our recorded vital signs or baseline vital signs. We will be doing a detailed systematic head to toe to pick up things that we were not able to focus on because we were doing our primary. or to pick up things that develop slowly. After you evaluate the ABCs and treat immediate life threats, a more detailed assessment should follow. Secondary assessment is a more systematic full body scan, typically occurs en route to the emergency department. Right, now physical exams or examination. Listen to breath sounds. Once there is blunt force trauma to the chest or abdomen, or you have a patient complaining of difficulty breathing, you need to listen to breath sounds or lung sounds. Determine the respiratory rate, know the pattern and quality of respiratory effort, assess for asymmetric chest wall movement. Ms. Jackson, what does asymmetric chest wall movement mean? What are they talking about? What is it that we need to look for? Ms. Jackson. Ms. Jackson, if your mic not working, type the answer. Ms. Nesbeth, what does asymmetric chest wall movement mean?
You should look for equal rise and fall of the chest. So outside of that, anything outside of that is abnormal. So that's it.
Okay. All right. Assess the neurologic system, assess the musculoskeletal system, assess all anatomic regions, right? And rarely in the pre-hospital setting, you'll get to do a detailed systematic head-to-toe patient that is critical. It rarely, if ever, happens. Vital signs. Reassess vital signs to identify how quickly the patient condition is changing, signs that indicate hypoperfusion and the need for rapid transport. So, if patient present with tachycardia and tachypnea with a low pressure, you know you have a patient in trouble. Weak pulse, cool, moist, and pale skin. These are important findings that indicate that your patient may have a perfusion issue or may be going into shock. Reassessment indicates how well the patient is tolerating the injury and the effectiveness of your interventions. Now, the final phase, the reassessment. This is where we will repeat our primary assessment, right? And we need to answer some questions as we repeat our primary. Are my interventions working for this patient? Do I need to make adjustments? You need to reconsider the chief complaint. Did you miss anything? And of course, we need to be doing our proper documentation and communication at this point. If the patient is critical, we reassess every 5 minutes. Patient is stable, reassess every 15. Right? So we're looking at our interventions. Assess and manage all threats to the patient's airway, breathing, and circulation. Give oxygen to the patients with traumatic injuries that impact the airway or ventilation, or those with a potential for shock. Expose all wounds, control bleeding, and be prepared to treat for shock. Flush small wound surfaces with sterile saline prior to applying dressing. It did not say flush large wounds, small wounds, right? So we don't flush large wounds in the pre-hospital setting. We may have to brush off debris, but we do not irrigate large wounds in the pre-hospital setting. Do not remove any material stuck to the wound. You cut around that. Splint extremities that are painful, swollen, or deformed. And as I say, you have to do your communication and your documentation. And it will be based on what the patient told you, what you observe, right? What you did based on your observation, how the patient responded to your treatment, and your method of transportation, right? So description of the MOI would be important. The position in which the patient was found, the amount of blood loss, location, description of any soft tissue injuries or other wounds, size and depth of the injury, how you treated the injuries. Go ahead, Ms. Nesbitt.
Sir, suppose you didn't get any time to do the documentation, sir, because you were busy trying to, patient went into shock in the ambulance, you're trying to maintain airway, you're the only person there, and the hospital is just a few minutes.
I've said this to you before, Ms. Nesbitt. At no point as a EMS provider you will work by yourself, right? So under no circumstances you should be managing any patient by yourself. So that's one. Two, documentation. There's no excuse for documentation not being done. If you didn't do any documentation, you didn't do any treatment. So if it was documented, it wasn't done, right? That is going to save you from legal problems. And in EMS, we say you have to learn to ride and whistle, right? You have to learn to ride and whistle. And one of the things that I used to do when I was riding the unit, because I don't ride ambulance anymore. One of the things I used to do is I used to have a piece of tape. So anytime I'm going on a call, I'll have a piece of micropore tape, the broad size, and I'll put that on my pants. So as I do checks or I find important information, I make jottings, I make note of it, and as soon as I reach into my unit, I transfer that information to my clipboard or chart, right? So you have to learn to ride on and whistle, as we call it in the EMS. But under no circumstance you should reach the hospital and don't have a report.
Sir, I'm not saying that I'm alone, but my partner is the one that is driving and I'm in the back of the ambulance. That's
Yes,
my
and that's how it's always gonna be. If you are the EMT work in the back, it's you alone. Your partner is at the front driving, and it is your responsibility to manage the patient and make important jottings on your chart and call the receiving hospital. It is a high stress job, you know. Being a EMS provider is not a walk in the park, but everything that I'm saying to you, it can be done, right? It can be done. Can be done, definitely. So let's look at let me backtrack. Okay. Let's look at the emergency medical care now for closed injuries. No special emergency care for small contusions. Extensive injuries could lead to hypovolemic shock. Closely watch area of injury, no matter how minor. So look out for your discolorations. Wherever you see discoloration on the patient's body, think about what is underneath that area. So if you see bruising and discolorations on the chest, you know that the lungs is under that area. The major blood vessel, the heart, you have to think about the structures that are underneath that part of the area and how vulnerable these structures are. Treat closed soft tissue injuries using the Rice's mnemonic, right? So if it's a soft tissue injury that's closed in the pre-hospital emergency setting, rest, ice, compress, elevation, splinting, right? Now, the Ice compress is in the early stages of the injury. Right? So there are some literature out there that state that no more than 6 hours with ice therapy, right? Beyond that, heat therapy should be considered. Now, signs of developing shock for closed injuries. Yes, Ms. Johnson. Go ahead.
So the ice is supposed to be on it for 6 straight hours, sir?
No, no, no,
Or is
no.
it interval? Oh,
That's not what I'm saying. Right? So in a pre-hospital setting, I'm not gonna have a patient for 6 hours. The most I will have a patient for is probably 45 minutes. Right? So I am talking about your 10 minutes of your golden period or golden hour. Right? The 10 minutes of assessing your patient, finding what the problem is, and treating the problem. Right? Packaging the patient and transporting the patient to the nearest facility. That's where your ice therapy is going to come in. And once we hand over, your ice therapy ends, right? Purpose of the ice therapy is to reduce swelling. Yes, Elizabeth. Go
And
ahead.
the ice therapy, is it those disposable bag things that you just squeeze up and it
Yes,
turns?
ice pack. Talking about the use of ice packs. So not 8 hours, Miss. Not over 6 hours, Miss Johnson. Just saying that there is literature out there that ice therapy can be used up to 6 hours. That is what I was saying. I'm not saying that's what is done in EMS. All right. So emergency medical care for open injuries. Before caring for the patient, you must follow standard precautions. It's an open wound. It's gonna get messy, right? If life-threatening bleeding is observed, assign a team member to apply direct pressure as soon as you pick that up. Cover wounds of the chest, upper abdomen, or upper back with an occlusive dressing. Anybody familiar with that term or type of dressing? An occlusive dressing? Okay. An occlusive dressing is an ear-tight dressing, right? It's an ear-tight dressing. And if a patient has a puncture wound to the neck, puncture wound to the chest, and an abdominal evisceration. These are three wounds in which we would consider the use of an occlusive dressing, right? If it's a puncture wound to the neck, the purpose of the occlusive dressing in that situation is to minimize the possibility of air get into the area, right, or the blood vessel, which can, in theory, cause an embolism. There's no data to support that air being pulled into vessels in the neck will lead to uh, an embolism, right? However, there are some surgeries that will require you to use the occlusive dressing for the puncture wound to the neck. And if you're using an occlusive dressing, you are going to seal all four sides if it's the neck. Right? Now you have commercial types. If you don't have commercial types, you can get a piece a plastic, and I'm drawing it now. So you can use the bag that your oxygen motor. You can use that as an occlusive dressing. When you put it on the neck, you seal all four sides, right? You seal all four sides when it's on the neck. Now, if it is a puncture wound to the chest, That's a sucking chest wound or an open pneumothorax. So every time the patient takes a breath in, air is being pulled into that puncture wound, and it can cause the lungs to collapse. We will use an occlusive dressing for an open puncture wound to the chest. Now, when you apply the occlusive dressing in that area, so you put it again, it can be the commercial type, which is not, it's not square, the commercial type is round. So the commercial type is a round dressing, and it has a flutter valve, right? It has a flutter valve. The one that we improvise using the bag that our O2 mask comes out of will have a square appearance. If it's a chest, you will seal 1, 2, 3. Only 3 sides if it's the chest, right? So if it's a puncture wound to the chest, we are only sealing 3 sides. Miss Jackson, why would I seal 3 sides for a puncture wound to the chest? Miss Jackson, are you present? Okay, type the response. Rowan, why would I need to seal 3 sides and not 4? Can I use your mic? Type the answer. Mr. Jennings, why would I need to seal 3 sides and not 4?
Afternoon, sir. So you would need to seal the 3 sides because when the person breathe out, the air that probably was already sucked into the chest would need to escape. So when the person breathe out in diaphragm, come back up, that opening would allow the air that's inside the cavity to come out so that you don't build that pressure.
Right. That's correct. That's correct. Good. Right. So we are sealing 3 sides to create a flutter valve. So when the patient exhale, air can come out. But when they inhale, no air is going in. So that's the purpose. If we seal 4 sides, we would trap the air that's there. The air would be trapped. Right? So that's good. All right. Now, if it's upper abdomen, you have to use a occlusive dressing as well. If it's the upper back, you use an occlusive dressing. Now, if it's an abdominal evisceration, okay, Mr. Okay, Ron, I saw that response. If it's an abdominal evisceration, it means that the abdominal organs are protruding from the wound. So there's a laceration and the intestines are outside. We do not push the patient's intestines back inside of the body, right? We don't do that. We're not surgeons. So the objective of the occlusive dressing at that point is we need to cover the protruding organs with an occlusive dressing to maintain moisture in the organs. Now, if you don't have a occlusive dressing that can fit the abdominal evisceration, you can use your trauma dressing, which is a large dressing that can soak up a lot of fluid, and you can wet that trauma dressing with sterile water or IV fluid and put that over the intestine and then cover it with a dry dressing. Now, controlling bleeding, we will use direct even pressure and elevation. We can use pressure dressings or splints, and of course, we can use tourniquets if we have proper training and proper protocols and proper medical direction. All open wounds are assumed to be contaminated, present a risk of infection. Control bleeding by splinting the extremity, even if there is no fracture, right? So even if you're not sure, it's better to stabilize, right? Because each patient is different. Each patient is different. I have patients that they had a soft tissue injury and they're screaming, they're bawling for pain. Oh, I think it fractured, I think it broke. It broke, right? You stabilize it. They go to the hospital. They do the X-ray. Look at the limb. The limb is fine. There's no fracture, right? And I've had patient where minimal pain, right? Not feeling much pain. Something fell on the arm. Not having much pain. Not showing much deformity. You stabilize it. When they go to the hospital and do the necessary checks, it's fractured. So it's very difficult to pick up certain things in the field. So it's better to be safe than sorry, right? And that's why evaluating the mechanism of injury is important. Now, abdominal wounds, an open wound in the abdominal cavity may expose internal organs. This is a abdominal evisceration, right? The organs protrude through the wound. Cover the wound with a sterile gauze. Secure the gauze with an occlusive dressing. Keep the organs moist and warm. If there is an impaled object now, so let's talk about impaled objects. So if there's an impaled object in the cheek or the mouth, the only time you will consider to remove this object is if it is interfering with the patient's ability to move ear. Right? So if the airway is compromised, you need to remove that object. If the object is in the chest, so if the patient has an impaled object in the chest, the only time we will consider to remove this object is if it is in a position that we need to put our hands if we need to do CPR. So if it's interfering with our ability to do CPR for this patient, it must be removed. And yeah, I won't say that now. That's for another topic. Now, neck injuries. Open neck injuries can be life-threatening. Open veins may suck in ear and cause cardiac arrest. This is a theory. It has not been proven yet that that is possible. Cover the wound with an occlusive dressing. Apply manual pressure, but do not compress both carotid arteries at the same time. What does this mean? It means that when you're bandaging the neck, you do not go circumferential. So you never wrap circumferentially around the neck because you can cut off the blood flow to the brain. So that's a no-no. Small animal bites. A small animal's mouth is heavily contaminated with virulent bacteria. Wounds may require debridement, antibiotics, tetanus prophylaxis, and surgical repair. Bites should be evaluated by a physician. Now, a major concern is the spread of rabies, acute, potentially fatal viral infection at the central nervous system. Can affect all warm-blooded animals, and it's transmitted through biting or licking an open wound. Prevented only by a series of special vaccines, right? Only by a series of special vaccines. Human bites. The human mouth contains an exceptionally wide range of bacteria and viruses. Regard any human bite that has penetrated the skin as very serious, and it can result in a serious infection and spread as well. So, emergency treatment. Apply dry sterile dressing, promptly immobilize the area with a splint or bandage, and transport them. to the emergency department. And that's it for your soft tissue injuries. Take a 13, we'll take a 13 minutes break. We will start back at 5 o'clock. So 5 o'clock on the dot, we will resume.